I'm very excited to be able to first introduce Dr. Adam Sachs. Dr. Sachs is a Director of Neuromodulation and Functional Neurosurgery at the Ottawa Hospital. He's an Assistant Professor of Surgery in the Division of Neurosurgery, an Associate Scientist at the Ottawa Hospital Research Institute, a member of the University of Ottawa Brain and Mind Research Institute, and an Adjunct Professor of Systems and Computer Engineering at Carleton University. His presentation is looking at VR and research with people with dementia, with Parkinson's disease. Dr. Sachs, thank you very much.
Thank you, Richard, and thank you to TLSS and the organizers for inviting me here to speak at this exciting program. My name is Adam Sachs. I'm a neurosurgeon at the Ottawa Hospital and principal investigator of the Sachs Research Lab. My lab has two primary focuses that encompass the two primary uses for BCI, or brain-computer interface, in neuroscience. The first is looking at inducing neuroplasticity. And so we use our treatment of patients with Parkinson's disease to research this. The second use of a BCI is as a communicator or controller of an external device in patients who don't have the ability to use their own limbs. So it's an assistive technology. And I'll present a little bit on the use of VR in both of these. Parkinson's disease is what I manage clinically as a neurosurgeon. And this is a picture of a deep brain stimulator. So I'll start with this. Parkinson's disease is a neurodegenerative disorder affecting about 1% of people over 60 years old. Pathophysiologically, it's characterized by loss of dopaminergic neurons in the substantia nigra. And the diagram on the top shows two slices of the midbrain. And on the left, you can see it's a little bit lighter than on the right. That's the loss of that type of brain cell in the substantia nigra. It's also characterized by Lewy bodies, which are, that's shown in the slide below, which is a histological slide showing a cell with a halo around it. And that's an abnormal protein, alpha-synuclein. It exists in all of the cells in the cortex. So the reason that I go back to this is because in deep brain stimulation, we're able to impact the motor elements of Parkinson's disease, but ultimately, there's also cognitive and mood elements that are more affected by this abnormal alpha-synuclein, and current treatments don't manage that. The motor symptoms include stooped posture, shuffled gait, rigidity, slowed movement, and tremor. And this occurs because the loss of dopaminergic neurons in the substantia nigra gives rise to an abnormal network. I won't go through the network in its entirety, but on the left is a normal network. The red arrows represent excitation, the blue arrows represent inhibition, and there's a balance that gives rise to normal fluid movements that those without Parkinson's disease enjoy. On the right, we see when you take out that dopamine input, there's imbalance. There's increased excitation at some levels, increased inhibition, and there's overall more inhibition of the thalamus. So treatments that are aimed at managing Parkinson's are aimed at trying to restore that balance. The other phenomenon that occurs as a result of this abnormal balance or unbalanced networks is synchronization of neural activity that occurs in a periodic fashion somewhere between 14 to 30 times per second. These are called beta oscillations. And the beta magnitude increases during maintenance of motor state, but during rest, tonic contraction, and motor suppression, like in a no-go task, it elevates beyond this. And so this can be shown over here. There's a decrease in beta and then an increase in beta between tasks. And so this is also increased in Parkinson's disease, and treatments that manage the symptoms of Parkinson's disease decrease the beta. And so this is a graph of what happens during high-frequency stimulation, and it shows suppression of that beta. And the degree to which beta oscillations and synchrony is suppressed correlates with the improvement in the motor symptoms. So improving beta can be a biomarker for recognizing how good management is, whether it's with dopaminergic medications or, once those fail, with deep brain stimulation. Deep brain stimulation is a treatment in which electrodes are placed in the specific areas of the brain and controlled by a small computer and battery that's surgically implanted beneath the clavicle. This is the surgery that I do as a neurosurgeon. This is a video of a patient. I actually want to turn the volume down. I have to turn it down because the next video is poorly edited and for voice. It's edited only for video. So this is a patient who has his stimulator turned off, and you can see in this case how much his movements are coming back, the tremor, and then when he turns it back on, the tremor disappears. In order to achieve this, the stimulator has to be placed in a very precise location in the brain, which is the subthalamic nucleus. And so the goal of surgery is accurate positioning of the DBS electrode. There are a number of nuclei in the immediate neighborhood, and so any offset by even a few millimeters results in unwanted neurologic side effects. And so as a functional neurosurgeon, this is the surgery that I do in the operating room, and the surgery is typically an all-day event aimed at just getting the tip of the electrode in the STN. To do this, we first use imaging and image guidance. So we register the fiducials that are surgically implanted in a patient. After the patient has a CT scan and an MRI, the CT and the MRI are co-registered, and we're able to, using a camera using a camera and spheres, able to localize where those fiducials are in reference to the imaging. However, this gets us in the neighborhood. It doesn't get us in the precise location. So we use a microdrive and microelectrodes to record from neurons and are able to make adjustments around 1 millimeter or 2 millimeter adjustments in order to get the precise location of the electrode. And this is done by listening to the sound of the neurons and the characteristics of the neurons, the brain cells. Each region of the brain has a slightly different signature of the recordings. And so we listen to these recordings and we're able to refine the positioning based on them. So this is an example from the operating room of the recordings in the brain. We're able to record from multiple channels simultaneously, so we can look not only at their characteristics, but at the interactions between characteristics. And this affords the opportunity to perform research. We have a person in the operating room, and some of them will choose to participate in research. So we take half an hour and use the fact that we've got recordings from the brain. We're in a controlled environment, and we can set up an experiment, and we use the virtual reality to assist in this in the operating room, to correlate physiology with behavior, and also to use the application of BCI that I mentioned. So specifically, we're trying to address the questions: can Parkinson's disease patients learn to control their pathological network activity? And does acquired control of pathologic activity improve Parkinson's symptoms? In order to do this, we have a setup which sets a network stream, which includes the recordings from the brain, the behavioral output, which in this case is the position of a wand, and also the stimulus that's presented to the patient in the virtual reality environment. And so this is one example of an experiment that we have. Because we're interested in movements, we have an experiment in which we're controlling the movements with a cue and various targets. and the participant has to move towards those cues. And this is an example of us using this in the operating room. So the patient who's participating is donning the virtual reality goggles, and in this particular task, they're asked to control the color of a sphere. So they control the sphere and turn it blue. If they're trying to imagine, they'll try to imagine themselves in a resting state with smooth movements, and they are prompted to turn the sphere orange by imagining themselves stiff and Parkinsonian. And the actual control signal for the color is the beta oscillations from the brain that we're recording from. Remember that beta is that biosignature of the Parkinsonian state. So we're using the VR in conjunction with brain-computer interface to try to induce plasticity and teach people with Parkinson's disease to control the abnormal signals that make them Parkinsonian. And on a population level, we found that we're actually able to achieve this after about 5 trials. Each trial is maybe 20 seconds or so. So this is a very short amount of time that they're able to, at first they're not able to achieve this, and then they may be using a strategy different from the ones that we initially prompt them, but they're able to reliably control the color of the sphere using the brain signals, and those are the brain signals that are abnormal in Parkinson's disease. So the next step, and we haven't done this yet, is to see if when you move your arm to the target in the virtual reality, are their movements becoming more fluid? Are they becoming faster? Are they more accurate? These are questions that we can address in the virtual reality environment, and that's the next step. So why do we use virtual reality? Well, we use it to create a sense of immersion in the environment. We use it because we can control the distances that the person is asked to do, and we can scale it appropriate for that person's symptoms, and we can control the experiment and set it up in an operating room that we otherwise wouldn't be able to conduct. Another reason that we do this is because we can ask even further questions about the fundamental physiology of networks that are involved in movement. We know that the brain processes movement in different reference frames. At one point, we look at the world and we see objects that we're interested in a reference frame on the retina, a 2-dimensional reference frame. At some point, that gets converted to a body-centered system. So if I turn my head, I'm still able to reach for that glass, which may not be referenced to my retina, but is referenced to my body. So our body has those reference frames as well. And lastly, they have world-centric reference frames and even specific object reference frames. And so these reference frames change during the brain, and we're able to do pupil tracking, head tracking, torso tracking, and limb tracking using virtual reality. And therefore, we're able to tease out what reference frames different areas of the body are involved in and may be able to target therapies appropriately. The other thing is that these are commercial systems. So it doesn't cost $50,000 to set up a neurophysiology rig in the operating room. And also because they're designed to prevent people from getting nauseous when they turn around quickly, there's a high refresh rate. So it's actually very good for the type of behavioral and psychophysics experiments that we conduct. So just to repeat this, we use it for stimulus control in these experiments, rich behavioral measurements, reasonable cost, and easy to set up in the operating room. Now, I mentioned that we do brain-computer interface research for induced plasticity in Parkinson's disease, and also as an assistive technology for people with ALS and spinal cord injury. And I'll go over this next set of experiments, which we have not yet conducted, but this is the majority of the focus of our lab right now is to start this, and our hope is to start in the very near future. People use their limbs through signals from the brain that are communicated through the spinal cord to the muscles. In patients with ALS or with spinal cord injury, the motor signals are lost, either through degeneration of motor neurons or through an actual lesion in the spinal cord. And so they're not able to use their endogenous system. Now, there are existing assistive technologies, but these technologies allow more utility based on how much disability you have. So patients who have only a small amount of disability are able to get much more utility out of existing assistive technologies. And this is what non-invasive brain-computer interface. This is the same space occupied by current non-invasive brain-computer interfaces. There's very little that can help people who are partially or totally locked in. Our goal with what we call the neurocognitive controller, NCC, is to fill this space and give good utility and assistance in people who are severely disabled. And we're doing it by recording not over the scalp, but in the brain, because when you record in the brain, we get direct, accurate recordings of individual brain cells, individual neurons, and we get a representation of the network if we have multiple recordings simultaneously. Whereas an EEG gets a very noisy signal of an average of hundreds of thousands of neurons. So we're doing direct intracortical recording using an array of microelectrodes that's about 4 millimeters, and you can see the scale by the penny behind it. The other thing that you could see is that the penny shows Abraham Lincoln. Currently, there are about 3 or 4 trials of using brain-computer interface. Ours will be the first Canadian one, and the first one to try to engage a different area of the brain, prefrontal cortex. And I'll try to demonstrate the rationale for believing that prefrontal cortex would be a good adjunct for a brain-computer interface. So first, I'll go over the overall setup. Signals are recorded from 1, or in our case, 2 brain areas. And those are neural signals that are amplified and converted using decoders that we have to build into a control signal. This is done in real time. In actuality, there's actually multiple steps in this conversion. They're amplified, digitized, and so we have multiple pieces of equipment that are set up in a network, still operating in what we call real time, which is latencies of less than 50%. This is not looking promising. Oh. And so we set this up to allow the brain-computer interface. This is an example of a cursor that's being controlled by a monkey with a brain-computer interface in the motor cortex. The task before the monkey is to move the cursor to the area on the grid that has a change in color and hover over it for long enough for that color to change. And we have a separate task, I don't have it here, in which the monkey moves the joystick with his hand. And his performance with the cursor is roughly equivalent to his performance with the hand. So this is a very high-performance brain-computer interface. This is a video from the BrainGate trial at Stanford and Brown University, which I was a part of during my fellowship. They're using motor cortex control, and this is a participant who cannot move her arms or legs and hasn't been able to feed herself for 8 years. And so this is the first time she's tried to use a robot. This is trial 1. And she's controlling it there's a cappuccino in this thermos. And so she's going to feed herself a cappuccino using an array of electrodes communicated through much of computers. This is a engineer whose job is to hit the stop button in the event that the robotic arm starts to do something dangerous. It doesn't. So she achieves her goal. And I'd like to show one last video using the algorithms that they used in the monkey lab, but to try to allow somebody to control a keyboard. And so this is a different participant who with a spinal cord injury who is unable to move her arms or legs. She has a brain-computer interface implanted in the motor cortex, and she's controlling a keyboard using the same type of brain-computer interface as we showed with the monkeys in the grid experiment. And this below shows her performance in terms of characters per minute. And she actually achieves performance of about 40 characters per minute, which is about 8 words per minute, using the brain-computer interface. But we want to be able to improve performance, both with robotic control and with cursor control. And so we are planning to implant, in addition to the motor cortex, in the prefrontal cortex. The prefrontal cortex is involved in working memory, attention, decision-making. It's a higher area of the brain in terms of cognition. And so if one can conceive of a motor cortex brain-computer interface controlling the moment-to-moment kinematics, where the concentration is on the exact position and the movement of the robotic arm, our goal is to some degree automize that and have a decision-making BCI controlled by prefrontal cortex, and perhaps have semi-autonomous movement by the robotic arm, or let the kinematic load rest on a separate motor cortex BCI in the same participant. I've been working in monkey prefrontal cortex for the past decade, and so I'll show a few experiments that we've done which gives us the belief that prefrontal cortex is a good location for a brain-computer interface. So in this experiment, the monkey is looking at a computer monitor and is prompted to look in one of 8 directions. There's an array of microelectrodes, the same one that we're using in the humans, implanted in the prefrontal cortex. We can record activity during, in this case, we're looking at eye movements, but it could be arm movements just as easily in this area of the brain. And we can get a recording profile which shows that there's tuning to different directions. So this is a neuroscience, neurophysiology phenomenon that's been demonstrated in multiple different brain areas, that if you record from an area that's involved in movement, you'll get a lot of activity in one direction, a little activity in the other, and therefore by having pools of neurons that respond like this, we can control limbs. We're not interested in single neurons. With statistical properties over multiple trials, we're interested in having a precise prediction of movement from multiple recordings. So we use a technique of dimensionality reduction and then machine learning decoders. Dimensionality reduction, quite simply, is the concept that if we're recording from 2 neurons, that's 2 dimensions. 3 neurons, that's 3 dimensions. If we're recording from 120 neurons, we need a way to make that convert that into a meaningful 2-dimensional movement. So there are ways of projecting this onto a lower dimensional space. That's what I mean by dimensionality reduction. I won't go into the details of the algorithm, but this is a key part of the decoding process. Once we have that lower dimensional manifold representation of the neural activity, we could then attempt to build decoders based on that. And this is a graph demonstrating that we're able to decode direction even before the monkey makes the movement. So the monkey is fixating on a central fixation point and is about to make the movement but hasn't done it yet. We have a decoding of the order of over 80% ability to decode one of 8 directions, which is a significant amount of decoding. And this experiment was designed before we implanted the array. So if we actually designed the experiment around what the neurons are meant to do, would probably have even better performance. So this gives us a reason to think that we can get some decoding out of this area of the brain. We did a second experiment to see if there's some plasticity in this area, because instead of moving the native limb, we want to move a robotic arm. So we did a similar experiment, except the monkey has 1 or 2 different potential targets, and a cue, which is an arbitrary in color, which indicates which target to look at. So if this is presented to any of you, you'd guess 50-50 on the first one, and then after that, you get 100%. Monkeys take 100 or 150 trials in order to learn this pattern, and then they ultimately learn it, at which point I hit the reset key, we get a new set of targets, a frustrated monkey, and performance goes back to 50%. So you would expect that the behavior would be a seesaw function of starting at 50%, getting up to 100%, back to 50%, and then going to 100%. In fact, that's what we found. So behavior is the blue lines. We start at guessing, and then the behavior goes up. The red line is the performance of the decoder that's based on the array that's implanted in the prefrontal cortex. We're able to quantify the performance of the decoder predicting the movement. And what we found is a correlation, in most cases, of the decoder performance, the red line, with the monkey's behavioral performance. So this leads us to think that this area of the brain is involved in learning, and that the cells may be able to change their activity. And what we found when we look at, there's this concept when we do this lower dimensional reduction of having weights on each of the factors. And so what we found is that when the monkey is performing poorly, there's a instability of some of these weights, and then they become more stable when that performance goes up. That further leads evidence to the theory that this area is involved in the learning, and therefore this might be a suitable target for brain-computer interface. So why use VR in this set of experiments? Well, first of all, we talked a lot about the decoders. We have to train the decoders. So in order to train the decoders, we have to take it through what the activity would look like in different areas of actual space. In order to do this with a manual representation using a robot would be either impossible or very difficult, because there would be some places in that space that the robot couldn't achieve, some configurations that the robot couldn't achieve, or that would be extremely laborious. And we have real people with real disabilities, so we can't spend time like with the monkeys, spending 10 hours a day trying to train the decoders. The second potential use is the fact that we're interested in prefrontal cortex. We're interested in the inherent meaning of objects. So we can change the inherent meaning of objects in virtual reality. You can't change it in real reality. I can turn an orange into a glass of Coke in virtual reality, change the meaning, understand the neural activity, train the decoders. Can't do it in actual reality. I can turn a treat into a predator, inherently change the meaning in virtual reality. We cannot do that in actual reality, and therefore we can get a better understanding of the prefrontal cortex and how to use it in a BCI. So again, in this area of neuroscience, in the NCC trial, we use virtual reality for stimulus control, to train the decoders, to generate tasks that would be either difficult or impossible to do manually with a physical design, and to create a sense of immersion in the environment, which hopefully will translate into increased agency over a non-native limb, a prosthetic limb, or over a computer cursor, and therefore increase performance. This is another reason that we're planning to use a virtual reality in this neuroscience trial. I'll close on that. Just wanted to mention the members of my lab, without whom research does not occur. Chad Boulay, who's with us, is a senior research associate and programmed, conceived of some of these experiments, programmed all of them, and is also involved in working and analyzing the monkey data. Liz Hassan is a postdoctoral fellow in my lab for another 4 days before she takes her position as assistant professor at McMaster University. David Liu is a PhD student in my lab, and we also collaborate with a monkey lab in which I conducted the experiments, and that this is the lab of Julio Martinez at Robarts University, and Matt Levitt helped with some of the data collection as well. Thank you.